So good evening, everyone. Apologies for the delay. So I welcome you all, and it's good morning in US and good afternoon in Nigeria and good evening in India. So let me just remind you all that we have people joining with us from all the part of the world. So I once again welcome you all on behalf of Team ISMSICS. So moving on forward, I'll quickly introduce you to the office bearers of ISMSICS. We have with us Dr. Amulya Sahu sir. He is founder chairman of ISMSICS. He has been past president of Bombay Ophthalmological Society. He is nationally and internationally acclaimed cataract surgeon who has introduced 2mm SICS technique. He is founder chairman of Sahu Eye Group of Hospitals. So over to you, Sahu sir, for your words of wisdom.
Yeah, thank you, Aarti. It gives me a great pleasure to be in this webinar. Nigeria, they are taking so much of interest, and it gives really a lot of pleasure that we are able at last able to reach out to Africa. And thanks to Aarti, he has opened the door for it. And there are a lot of scope for developing SICS there. So I hope we will find a way how to train those people in the art of cataract surgery. So with these words, I just want you to carry on the program. Thank you.
Thank you so much, sir. So next we have with us Dr. Jagannath Gulamani, sir. He is executive chairman of ISMSICS. Among the finest ophthalmologists in the city, Dr. Jagannath is in Mumbai, based in Mumbai, and it's known for his offering excellent patient care. He has contributed exceptionally in bringing a change in MSICS technique, and his technique of modifying the astigmatism in MSICS is going to be soon published. He'll be joining us shortly. So next we have with us Dr. Parikshit Gopte, sir. He's vice chairman of ISMSICS. He shares his interest in cataract surgery, community eye health, pediatric ophthalmology, training, and research. He was the head of Department of Community Eye Care, Orbis supported Department of Pediatric Ophthalmology at HV Desai Eye Hospital. He is founder of Gopte's Eye Clinic, which is in Pune. Next is Dr. Satanshu Mathur, sir. He is Chief National Coordinator of ISMSICS. He is Medical Director of High Tech Hospital, which is based in Uttarakhand. Asia Pacific Academy of Ophthalmology of Ophthalmic Education Committee has been blessed as he was member. He has been Honorary Secretary of TARS Chapter of Community Ophthalmology, and he has been Scientific Committee Chairman, Association of Community Ophthalmology of India. Next, we have with us Dr. Bhattacharya, sir. He is president of ISMSICS and he has been past president of AIOS. Dr. Srinivas Joshi, sir, who is young and dynamic ophthalmologist based in southern part of India. He is secretary of ISMSICS and he is a renowned vitreoretinal surgeon. So next is me. I really don't want to introduce myself. So next we have with us. Moving on forward. I'll be moderating this session with Dr. Mustafa. And let me quickly tell you that this webinar is actually the idea of Dr. Mustafa, and he has taken all the initiative. So thank you so much for it, Dr. Mustafa. He is Assistant Secretary of ISMSICS Nigeria Chapter. He is Consultant Ophthalmologist at Usmanu Danfodio University Teaching Hospital in Nigeria. So next, Dr. Mustafa, would you like to take from here?
All right. Next. Dr. Nepalia is the ex-senior professor and head of Department of Ophthalmology at the LM Medical College, Ajma. Also a senior consultant at St. Francis Hospital in Ajma, is a past president of Rajasthan Ophthalmologic Society and a Lifetime Achievement Award by Rajasthan Ophthalmologic Society in 2018. And he is the pioneer of SICS in Rajasthan, India.
So Dr. Nepalia, would you like to speak a few words of wisdom for us?
No words to prize, but it's a wonderful opportunity to interact with one and all and be there as a part of this wonderful event.
Yeah, of course. Next, we have Dr. Susan Mcdonald, Associate Clinical Professor at Tufts Medical School, at Tufts School of Medicine, and she's the President of ICO, Residency Co-Director at Lihead Clinic, and also have Teaching Excellence Award from Tufts and a Cataract Surgery Trainer. Thank you for joining us.
Dr. Susan has been very active in Tanzania when it comes to ophthalmology. Dr. Susan, would you like to speak something? Okay, so let's move on. Maybe she's not connected at this time with us.
Next, we have Professor Nasir Muhammad. He is a professor of ophthalmology at the Usman Danfodio University, Sokoto, and also an excellent pediatric ophthalmologist with the teaching hospital here in Nigeria, in the teaching hospital Sokoto, Nigeria. So, you're welcome, sir. These are the office bearers.
Pleasure
we have.
here.
Thank you, sir.
So, yeah, so let's hear from Dr. Professor Nasuru as well.
Yeah.
It's my pleasure joining the panelists and look forward to an education session from the speakers.
Thank you so much, sir, for finding time to join us. The ISMICS Nigeria office bearers include Dr. Adamu Dantani, who is an associate professor with Usman Danfodio University, Johnson Sokoto. He's the chair. Then Dr. Achibu, the vice chair, Dr. Murtala, the secretary. And we have a whole list of members of the scientific committee. You are all welcome to this session.
So Dr. Mustafa will quickly introduce all these speakers, and then we will start the talks one by one.
Okay, Dr. M.S. Ravindra is a medical director, Kartik Netralaja, Bangalore. He's one of the most respected and renowned doctors in the field of ophthalmology. And Dr. Ravindra brings with him a great amount of experience in the field of cataract and vitreoretinal surgery of more than 41 years. Welcome to this session. We'll be glad to hear from you. Next is Dr. Meeta Joshi, Associate Professor, Community Ophthalmology, School of Excellence for Eye, Indo, ex-professor, Amalthus Institute of Medical Sciences, Dewas, ex-assistant professor, Sri Aurobindo Institute of Medical Sciences, Joint Secretary, Madhya Pradesh State of Ophthalmic Society, Secretary MP Chapter Executive Member, and founder member of Women Ophthalmologists Society. Nice to have you in this session. The next speaker is Dr. Surab Patwadan, presently working as consultant vitreoretinal ROP services at Nanda Deep Eye Hospital, Sangli, Director of Fellowship Program at Nanda Deep Eye Hospital, Alliance Eye Hospital, Sangli. He is the MD ophthalmologist, Dr. RP Center for Ophthalmic Sciences in New Delhi with a gold medal, and senior residency in vitreoretinal ROP unit in RP Center. Welcome for this session. The next speaker is Dr. Abdullahi Sadiq. He's a consultant ophthalmologist, a glaucoma and cataract surgeon with the National Eye Center, Kaduna, and also the Deputy Chair, Medical Advisory Committee of the National Eye Institute in Kaduna, Nigeria. Thank you.
So thank you so much. And Dr. Mustafa, I must appreciate that you pronounce the Indian names so well. That was really good. Yeah, so without further delay, we will start our first talk. And Dr. Saurabh is going to give us our first talk.
Yeah. So thank you so much, Dr. and Dr. Sausa, for giving me this opportunity. And thank you, Dr. Abdullah, Dr. Mustafa, Professor Nasiru, and Dr. Susan to be there for the talk, and Nigerian colleagues because they came more, and it is always exciting to work with my Nigerian colleagues who are always eager to learn better techniques. So here what I'm sharing is a rule which I devised when I was training fellows and colleagues. I thought that there has to be a simpler method to understand. Am I audible? Aarti, am I audible?
Yes, sir, you are audible.
Okay, okay. Yeah. So I thought there has to be a simple rule to understand the technique of capsulorhexis, how to get it a perfect one and avoid extension of rhexis, and how to get a perfect size. So this rule has helped many of my trainees, and I get compliments from many of the surgeons who are struggling with rhexis. When they see this video, they tend to do better with capsulorhexis. So I would request Dr. Aarti to play the video with the audio, and at the end I will make few comments.
Let's investigate the rule of center of triangle. We cataract surgeons know that capsulorhexis is the most essential part of the surgery, and we commonly use the cystitome made from 26 gauge needle. And in a regular case as well, we find this happening. The capsulorhexis, which is going on smoothly, suddenly starts going outward. And when I looked into detail of the maneuvering of the cystitome, I found that I was holding the flap at the wrong position. This led me into investigating all my cases, the surgical videos, and finding out what goes wrong and what should be done to make it right every time. And that led me to formulating the rule. I call it the rule of center of triangle. This is the rule that will help me in all my future capsulorhexis to get a very reliable and reproducible capsulorhexis. So what is this center of triangle? This is an imaginary triangle of 1 to 1.5 millimeter side each, and the apex of this lies at the advancing tear. One side along the flap fold and another side along the flap margin. When your cystitome holds the capsular flap at the center of the triangle, we get maximum control over the further movement of the flap. So that is the rule of center of triangle. So let's find out this case where I am demonstrating the rule. This is the first radial tear which is made, and then the flap is folded. Folding the flap over the anterior lens is very important. Now you can see that imaginary triangle, and I am holding this flap at the center of it. The moment I advance the flap, again a new imaginary triangle is formed, and I am going to hold it at the center. So this will keep on happening all around as I move my capsulorhexis around. This is more useful particularly in the subincisional area, that is where there is a higher risk of capsulorhexis going out. So again, I am carefully imagining the triangle and holding at the center of this triangle. To look it further into detail, you can find this imaginary triangle here, and I am careful to hold that flap at the center of this triangle, giving me full control over the movement of the flap. So as the capsulorhexis advances, I'll be repositioning my 26 gauge cystitome at the center of the triangle and advance the capsulorhexis further. These are the common errors when we don't follow this rule. First error is when you are holding away from the tear edge, nowhere near the center of the triangle, and this leads to uncontrolled flap advance. When the flap advances uncontrollably, it may go outward into the zonular area and may lead to capsulorhexis extension. And you will find this in your previous surgical videos, that this is the common error which happens when you have extra large capsulorhexis or the rhexis going into zonules. So to bring it back, again you have to hold the flap at the center of the triangle. Just watch here how I do it. That gives further better control over the capsulorhexis and bring it back. The second common error happens when you lift the flap at the flap fold. That is very common and very subtle error. You can find here that whenever the cystitome holds the flap at its fold, the direction of the capsulorhexis tear immediately changes. And the subtle change in the direction of the capsulorhexis will lead to further enlargement of the capsulorhexis. So after forming this rule, I went through lots of videos and also started using this rule in my day-to-day surgeries. I found that this rule was exceptionally useful for me to get reproducible and well-controlled capsulorhexis. So the rule of center of triangle is going to help us in getting a very good capsulorhexis in all our surgeries. Though of course some basic rules we have to follow, like maintaining the anterior chamber, keeping the flap folded, using heavy OVD in difficult cases, and maneuvering to small incision. And then we can get a very good result in our capsulorhexis using the 26 gauge cystitome. Thank you very much, and do apply this rule in your next surgical case. Thank you.
So thank you, Dr. Aarti. I think that was the video presentation, and
Can I have a question from Dr.
I would appeal to all the surgeons who are seeing this. Now, when you start doing the next case, you can. Yeah, sure.
Dr. Aarti,
Yeah,
Yes.
sure, sir.
can I have a question for Dr. Patwardhan?
Yes, sir, please. Dr. Saurabh, you're there, right?
Hello, I can't hear you, sir.
Saurabh, sir, your network seems to be a little unstable.
I can hear.
Yes,
Dr.
yes.
Patwardhan, Dr. Patwardhan,
Yeah, go ahead, sir. Ask the question, please.
when you are highlighting the error number 2, that was when the capsule gets folded, I thought Atreta would be a better choice compared to the other instrument.
So this rule of triangle was for capsulorhexis using the cystitome.
Mm-hmm.
So these are the errors which surgeons create while creating the capsulorhexis using cystitome. So once you avoid holding at the flap fold and away from the center of triangle, we get a very reproducible rhexis using cystitome. So if you are using capsulorhexis forceps, you have to follow different rules.
Okay.
May I comment?
Yes, Dr. Susan.
I just thought that was a fabulous,
Sure,
presentation.
ma'am.
It really explores exactly the issue of how important the position of the flap is, as well as where you're grabbing. But I love the idea of focusing on that triangle, because I think some of the mistakes we encounter is when we don't have the flap in the proper position. So congratulations.
So,
Thank you.
yeah. So anybody would like to comment anything?
And after this video, in fact, I have just studied my trainees and fellows. So
Looks like Dr. Saurabh is in a place where there are a lot many dogs as well. So
No, I think it's coming from somewhere else. Not me.
everybody
Okay.
else is muted, I thought. Okay, sir.
Okay. Yeah.
Yeah. So Dr.
Okay,
Mustafa,
so,
can we move on to
no
our
more
next?
questions?
Yeah, sir. Maybe I'll just check the chat box as well.
Sure. Yes.
Yeah. So can we have Dr. Mustafa? Can we move on with the next talk? Next, I invite Dr. Mita Joshi, ma'am. She's going to talk to us about perfecting the circle. So over to you, ma'am, for your presentation, and you can share your screen.
Right. So am I audible?
Yes.
Right. Thank you so much, ISMSICS, for this opportunity, Sahul sir and the whole team. And Dr. Patwardhan, that was a very excellent talk, which showed us the basics. And we'll be just working on a few of the practical tips which we need to do while doing a rexus. And what you need is basically to concentrate on the size, the shape, the centration, and what complications can occur. So basically, we'll just see a little bit of the anatomy and the forces which act during the capsulotomy. And as you all know, the basement membrane of the capsule is made up of type 4 collagen. It is synthesized inside out and is usually around 11 to 15 microns in thickness. And the posterior pole is around 4 microns, and it is 7 microns at the equator. So what we do is we just open the entire capsule, and we can either have a can opener, we can either have an envelope, or we can do the CCC. I'm sorry for that interruption. And the type of forces which act are the stretching or the ripping forces. And like Dr. Patwardhan showed in the view, where you just grab the capsule by the edge, where the ripping then occurs, and it can go out of control very easily. While if you do shearing, then the force is in the plane of the least resistance and minimal force is required. So this is the principle behind what we always say, that you keep the flap of the capsule folded at all times and use visco to keep it flat. Again, you have to look for intralenticular forces and the intravitreal forces, because intralenticular in hypermature cataracts and cases where you will have a lot of pressure occurring in the lens, the rexus can run out. And in vitreal forces, especially in cases where the patient is obese and you have a very short neck and he's breathing heavily, or you have an asthmatic who is lying down on the table, the intraocular pressure, intravitreal pressure rises, and that again causes the rexus to run out. Shape of the rexus can be oval or circular. Usually a size is around 5 to 6 millimeters, so that it should be ideal to allow your manipulation, and it should overlap the IOL optic by 0.5 millimeter, so that the IOL remains in place and the capsule can adhere without causing any problems. What you can use for the rexus, you can use the cystitome, the utratas, and the side port capsulotome. And how do you make the cystitome? This is a small video which shows you, first you bend the tip of the 26 gauge needle, and then you can just again bend it at near the hub. So the tip, you bend it at around 45 degrees, and at the hub around 80 to 90 degrees. And this is how the envelope capsulotomy is done, that you first have an incision, linear incision, and at the end of surgery, when you have put in your lens, or once you are sure that your nucleus would be able to come out, that time you can just extend the rexus with the forceps. Can opener is one of the preferred techniques, one of the techniques which we start with when we start doing the surgery. And there are usually multiple punctures in the entire capsule. This again is a technique which you can fall back on anytime you have problem. But the important thing is you either have radial or tangential cuts in the capsule, and you make multiple small punctures. Ideally, what we teach our students is you make 60 punctures, 15 in each quadrant. so that it gives you a very fine edge and there are no risk of any tags getting caught in your IA or causing any extension. Advantages of the CCC, it reduces the zonular stress, safer hydro procedures, you can have IOL in the bag, and in cases of an adventant PCR, you can have a good sulcus support, which sometimes goes missing when you do a can opener. But then again, it is a tricky learning curve, and you can have problems with a smaller axis, difficult to bring out the nucleus, or larger axis, which may cause repeated prolapse of the nucleus during your procedures. This is how you start off. Make a nick in the NTA capsule for 2 to 3 millimeters, and once you are sure of your flap, you can just lift, pull it, and just keep on moving your position so that you are grabbing it, like Dr. Patwardhan said, in the center of the triangle. And this is one area which is very tricky, the subincisional one. So you have to be very careful here. Try and push the capsule which has already been cut to one side, to one center, so that you are able to visualize the edge at all stages. This is one very important point, that you have to be able to visualize the edge at all times so that it does not run into the periphery. Again, use of viscoelastics is very important. You have to have your chamber formed at all stages, and so that the capsule is remains flattened, and then you can proceed with your rexus. Few important points regarding the sizing of the rexus. How do you know that this is a 5 millimeter, 6 millimeter, 7 millimeter? One thing which you can use is your routine calipers. Just put a small mark on the cornea, or you can use a bit of the trypan blue dye and dip your calipers in it and just put it there so that you have an idea. Or you can use an old blunt trephine. Just very gently leave a mark, nothing else, and then it just on top of the visco, so that it gives you an idea how larger axis you are supposed to make. Or you can use the old RK markers also. Instruments of rexus, we have seen one is the cystitome, which we have. Another one which can be used would be your Utratus forceps, and then you can use your so you can either use your Utratus, or you can use your microforceps, which can go through a small incision. Again, the principle of grasping and regrasping has to be done so that you are near to the edge of the rexus. And the Utrata again helps you in condition where there are fibrosis occurring, so that you can just use it to pull it properly. And so we can have the intraoperative advantages of the rexus, where you limit the radial tears, have less stress, and easier procedures for removing the nucleus. Post-operatively, again, you have displacement of IOL is prevented, and you have uniform distribution of the forces. So there is no dislocation or just moving of the IOL. Again, difficulties, we have seen rexus escape. So deepen the NTA chamber and then try to get it back into from the periphery to the center, or you can go into the other direction. right? And make a nick and come again to the other stage. Or if you find it is too difficult, you can just convert it to a can opener. Or you can just use your simple vanas and make a flap. So in this case, you can see it is going to the periphery, and we'll be just putting some more viscoelastics there, and we can see where use a vanas so that a flap is created, and you have a new starting point of the rexus, so that you can just start fresh and be wary of that point whenever you are taking your instruments to the corner where the rexus has extended. So you have to be careful in the next steps of the surgery. So here you resume your surgery again. This is one of the nightmares which occurs where you have, you have the Argentinian flag sign in mature cataracts with a lot of liquefied cortex there, and the pressure is very high. So there you go, it rips off. And what you can do in these cases is either you start off with a small rexus, or just simply use a vanas to have a flap, small flap raised, and you can use that to extend the rexus and get a perfect circle in those areas. But you have to again be wary of the area where the rexus has extended into the periphery. Again, small rexus, you can put nicks and just enlarge the rexus. Or in this case, you have an onion peel appearance where you can just, instead of just finishing your rexus, you can go into the periphery and enlarge it at the same time. So that is the onion peel technique, where you can extend the rexus and make it to a larger size in the first attempt itself. This is one of my favorite videos because this one uses all the techniques possible. We start in a mature post-traumatic cataract. We started off with the cystitome, but then it was too fibrosed to proceed further, and there was a risk of extending into the periphery. So then we used a vanas, and we used the capsulotomy forceps to pull it into the center. And then that allowed us to kind of complete it while using all the equipments of rexus which we have in our armamentarium. So thank you so much, and sorry for the disturbances. Actually, I'm still in the hospital and we have some meetings going on. So I had this in between. So thank you so much.
Thank you so much.
Dr. Meeta.
Yes, sir.
You had an excellent talk. Thanks for that. Since you have mentioned about can opener, I wanted your small and a quick comment about the envelope capsulotomy. Does it still hold any role in the present era of rexus, or it has almost become an obsolete sort of procedure?
It's almost obsolete, sir, now, but at least you should have in your mind that it is one of the fallback things which can be used, because ultimately your hands will do what your mind knows. So in case you are caught up in any situation, you can fall back on that, but it is now like very rarely used.
Number two, you have made a primary rexus, smaller one, taken out the nucleus and done everything, cortical wash up and everything. Now you are pushing the IOL and you enlarge the rexus. Now, during this enlargement of rexus, if it runs away, then how would you handle it?
So one thing is, during that enlargement, you don't have any posterior support at that time. So it will be only the IOL which is there. And again, the same thing, we can use the vanas to make a nick and bring it in the center, because posteriorly you won't have any support. So it would be a risky provision doing it that way.
For enlargement, you would prefer a treta or a cystitome?
Utrata would be preferable, sir, because and even the nicks which we make, they should not be radial to the center. They should be tangential so that it doesn't extend into the periphery. The small cuts which would be making would be tangential rather than radial.
Well, anyway, I am used to Utrata. I am so happy in all my cases. Thank you. Thank you for sharing your experience.
I wanted to say that was a fabulous presentation. And I agree with you that all of those different techniques need to be part of a surgeon's skill set, because you never know when you're going to have to use the Van Ness scissors or switch to a capsulotomy with the can opener technique. I also want to suggest that you showed something that was really important, and that was the use of trypan blue during the capsulorhexis. And I think for anyone that's having a challenging case, this is so critical for patient care, because being able to see the capsulorhexis during a difficult case really helps you avoid making a mistake, because you actually see what's happening rather than trying to.
Mita, can I come in, Arthi?
Yes, sir. Yes, sir.
Mita, you did a small rhexis to deliver the nucleus, and afterwards you extended it. And why not extend in the beginning? And if you are delivering a nucleus through a small opening, you are bound to put a lot of pressure on the zonules, and many a time zonule gets separated. So what was the idea of having a small rhexis and then extending it while putting the lens?
Sir, that was actually for the showing that onion peel method, kind that when you are doing and when you realize, sometimes what happens is we feel that no, we need a smaller rhexis in this case, but while planning for a smaller, it kind of becomes more smaller, 4.55 millimeter, and we aim for a 5.1. So in those cases, you can just extend it while you are doing the rhexis itself, instead of ending it at that point, extend it from there itself. And sometimes what happens is, if the nucleus is soft or something, it would be able to come out through the smaller one, but then you realize that it is overlapping on the optics of the IOL too much, and then that would again cause problems. So if only required, then you can extend it at that time. Otherwise, it would be at the time of this thing only.
Mita, you are a master, so I am bringing this point for the beginners or those who are struggling with the rhexis. So they should always aim for a bigger rhexis. Not seeing they will plan a small rhexis, try to bring out the nucleus and then mess it up. So when you are doing this, you have to explain to these beginners, but don't do this because I can manage, you may not.
So for beginners, a large rhexis is the norm.
Yes. You can manage anyhow, but for them it is a mess. Okay.
Dr. Sahu sir.
Yeah.
I hope from micro incision you are not turning into a micro rhexis. They may come and you may go to micro rhexis and perform the surgery. Because you are a magician. Because you are a magician.
There are certain Lakshman rekhas nobody should cross.
Can I just say, I appreciate your comments so much, because this is probably the hardest part of the surgery for me in small incision cataract, is delivering the nucleus into the anterior chamber. And it makes it so much easier when you have a larger capsulorhexis. And so I appreciate your comments.
Yeah.
Dr. Nasiru, Professor Nasiru, would you like to comment something?
Yeah, I think for our settings, we really see the large nucleus Susan just talked about. So you really need a relatively good size opening to deliver that nucleus. And importantly, trypan blue, we see lots of white cataracts. And sincerely, it's very difficult to really keep a good view of that capsule to get your rhexis going. So trypan blue, for many of our settings here, it's an essential stock you need really to do well with your rhexis. when you have immature cataracts, like it's demonstrated, it's easy to really follow your capsule and move on with the age. But once it's a white cataract, it's really, really a challenge. So I think that's one key point. I think in Africa, we still see a lot of white cataracts. Thank you.
So we do see white cataracts in India as well. So maybe Dr. Susan, if she is in US, she might see less of them. So moving on to our next speaker, I invite Dr. Sadiq to please share his screen and start his presentation. Dr. Gulamani sir has joined us. Yeah, thank you so much for joining, sir.
Yeah, thank you, Aarti.
Dr. Sadiq, you are muted. Maybe you can unmute yourself, please.
Okay. Oh, thank you, everybody. It's a great honor and it is a great honor for me to be part of this symposium. And I must say that I have learned a lot from what have been discussed so far. And actually, Dr. Mita has done my presentation. So all I'm going to say, she has already said that. But I was asked to talk about converting to CCC. And, oh, sorry, what's going on here? All right, like she has already talked about this in the different technique of capsulotomy. We talk about, because in cataract surgery, the most important thing or the basic thing that is done in cataract surgery is to remove the nucleus and then replace it with intraocular lens in the place of the nucleus that had been removed. And these are the various, therefore you need an opening for you to remove the nucleus, and these are the different technique of capsulotomy: can opener, envelope technique, continuous curvilinear capsulorhexis, and femtosecond laser-assisted capsulorhexis. But basically, irrespective of the type of technique you are using, there are some basic principles for capsulotomy. It should be large enough to accommodate the lens. Oh, sorry. It should be large enough to accommodate the lens or lens fragment without causing any complications. The whole idea is to remove the nucleus out of the valve into the anterior chamber, then from anterior chamber into the exterior. So for you to do that, you need to have one adequate size rhexis, especially what in this part of the world where most of our patients present with hypermature cataract. You need to have one adequate size rhexis. If the rhexis is small, it can lead to PC rentit, which is too large to have instability of the LOL later. I should be sufficiently stable to prevent anterior capsular tears from extending to the posterior capsule. And ideally, it should cover, should overlap the IOL optic in 360-degree fashion. And this is quite important because it prevents posterior capsular opacification and also ensures centration of the intraocular lens. And this is can opener, radial incisions have been made here. And then these are some of the disadvantages of the can opener. It has already been highlighted as risks of radialization, the tiny radial cuts at the anterior margins of the capsule during hydrodissections or nucleus prolapse. They can actually extend to involve the posterior capsule. And also, of course, during cortical removal, there's that risk of aspirating tags. And it also do not allow a complete overlap of the optics, and a limited opportunity to do some maneuvers, especially if there are complications like PC rent and you want to put the lens in the sulcus. There's limited opportunity to do that with Another type is the envelope technique. In envelope technique, which is commonly performed I use this when the patient has calcified anterior capsule with hypermature cataract. A linear incision is made on the proximal part of the lens. And this can be done actually with a cystatome or sometimes, most of the time, with keratome. And from here, the lens, it can be extended sideways using Banner scissors, and then you can use either cystatome or capsulorhexis process to complete it. It's a very simple procedure, but it also has some risks of anterior capsular tear because of the longitudinally oriented line of incision. It's also difficult to provide 360 overlap of the optic, and also increased risk of PC rent. So why PCC? Why are we so much interested in the continuous curvilinear capsulorhexis? And it has already been said, it's allowed for safe hydrodissection. You can easily go do your hydro procedures, hydrodissection, hydrodissection. And because of the continuity of the anterior capsular margin, unlike in case of can opener where there is tucks and there are weak areas, in CCC there are no weak areas, and therefore it resists radial tears. And one of the advantage of the CCC, you can always go behind the lens, behind the capsule, and remove all the cortex upon empty bag. Of course, you can always inject your lens into the bag and it becomes stable. If you have any PC rent, you don't have to be panicked. You can always insert your lens in the sulcus. Now, how do you combat the CCC, especially in this part of the world where most people are doing can opener? Actually, CCC is one procedure that you cannot, it's very difficult to start it in the human eye. So everything has to start from the wet lab. You have to understand the basic principles, the instrument needed, and then a good patient selection, especially as a beginner. Now, this is the wet lab. This is cataract that was induced. If you take this actually pig eye, but you can also use goat eyes. And if you microwave it for 5 minutes, you end up with something like this. And then you can use the microscope to practice rhexis. So when your hands are good, then you can move on to the human eye. Now, you need to understand that rhexis should be round, continuous, it should be centered, and it should overlap the IOL edges. Now, for you to have a successful rhexis, you need to have good pupillary dilatation throughout the surgery. And actually, this can be achieved either through the use of intracameral adrenalines or pilocaine. We need to also have a good visibility of the anterior capsule. Now, in patients that have mature and hypermature cataract, you really need to stain. And after the stain, it also takes some few minutes, take a longer time to pick the stain. But for patients that have grade 1, grade 2 cataract, you can actually, if you can see the red glow, you can do capsulorhexis without staining. And one of the important things is that in capsulotomy, you need to have form anterior chamber. Throughout the surgery, anterior chamber has to be formed, because in rhexis, the pressure in the anterior chamber should be more than the pressure inside the lens. And in so doing, you won't have extension of the rhexis. And one of the things you need to do to ensure the AC is formed is you need to have small entry. You don't have to open the wound too big when you're entering, when you're doing capsulotomy, because as visco is exiting the eye, the eye is becoming shallow and the lens is coming up. And preferably there shouldn't be any capsular fibrosis. Now, I prefer to use cystatome. And one good thing about this cystatome that you need to know is that even the angulation here, not this one, it can be modified according to the depth of the anterior chamber. Like this, if the anterior chamber is deep, you can use something like this. But if somebody has, let's say, angle closure glaucoma, the anterior chamber is shallow, you need to make it a little bit toward 90 degrees. And I like this angulation because it can easily make straight incision on the anterior capsule so that you can leave the capsule to start the rhexis. So another thing is case selection for a beginner. You don't have to go with white cataracts. They are always problematic. You end up having Argentine plaque. But in a good hand, it's possible. Now, some little useful tips. Raise only the flap without disturbing the cortex. When you're starting the rhexis, when you're raising the flap, it should be only the capsule, not the cortex. When the cortex and the capsule are mixed together, it's impaired the visibility of the rhexis margin. And then keep the flap flat always. And this can be done by continuous injections of visco. Once you see that the flap is trying to raise, it means the AC is becoming shallow, and then you need to put a lot of visco to keep the flap flat. And then be mindful of the cardinal points, the 12 o'clock, the 6 o'clock, the 3 o'clock. Most of the time, rexis extensions occur at that point. And also watch for external extensions. Once you see rexis is trying to extend, you can draw it towards the center. And if it has reached to the level of the zone roots, then you may have to use banners to redirect it, or you can start from the opposite side to complete the capsular rexis. Now, most challenges faced by beginners: loose rexis extension, small size rexis, and then difficulty in maintaining the anterior chamber during the procedure. For rexis extension, you need to identify the case at risk: white cataract, white milky cataract. You can take some precautions. You can over-pressurize the eye to ensure that the pressure of the anterior chamber is more than the pressure of the lens. And then you can decompress the lens using insulin syringe. You can get into the lens and aspirate the liquid component of the lens. And by so doing, you can physically see the AC becoming deeper and the lens shrinking. Or you can do double rexis, as been explained, or you can do, and then spiral rexis. Now, in conclusion, CCC has revolutionized cataract surgery since its introduction in the 1980s, and it remained the gold standard of capsulotomy for phaco and SICS. Thank you.
Thank you so much, Dr. Sadiq. You have covered the topic very, very, very well. So, does anybody want to comment, or maybe we can reserve the comment for the end? Nepalia, sir, you are muted. If you are trying to comment something, please unmute yourself, sir.
Dr. Sadiq really deserves an applaud for a wonderful talk. He has very nicely outlined the points in relation to CCC and what a beginner should do and how it should learn. And he has very rightly highlighted the importance of wet lab exposure, and a few of the points raised, highlighted by him, were of paramount importance. Dr. Sadiq, as a PG teacher, would you like your post-graduate to learn can opener capsulotomy first and then convert to CCC, or directly he should learn CCC?
Well, actually, I will prefer to start CCC straight. Yeah, because actually CCC give you a lot of confidence, and it reduces complications, and it emboldens you as a surgeon. So if I have my, I will ask all my residents to start with CCC straight.
I just want to comment that I was trained on CCC and did very few capsulotomies, and then I transitioned to working in situations where we're using very difficult cases, and I thought it was a deficit on my skill set not to be really competent in capsulotomy. I think that it's an amazing backup plan, and if it really needs to be taught to the residents in a way so that they're proficient in it, because it really is the way you bail yourself out when you get into trouble.
Very true. So we have Dr. Gulamani sir would like to comment something here.
Yeah, very nice talks, everyone. I just want to add few points. One thing is that you can do the rexis through the side port using a microcapsular rexis forceps. But suppose if you don't have microcapsular rexis forceps and you want to do the rexis through the side port, there is one more method. If there is no proper support, you can do with the needle if there is proper support. But if the cataract is, say, Morganian cataract, there is no liquefied nucleus, you don't get a good support. So whenever you want to do rexis through the side port without microcapsular rexis forceps, there is one more technique that is called as vacuum capsular rexis. Insert any fine cannula and attach to a silicone tubing and a syringe. So with the left hand, you can suck that cannula and just hold the capsular flag with that suction. through the fine cannula. It can be something like even your air injection cannula, which is bent downwards. So with that, if the capsule flap is caught with the suction, you can continue very with, because that grip is almost like a grip with a forceps. So with the cannula only, you can apply a suction and proceed for the continuing the capsular axis. If you want to loosen that grip, again push the piston of the syringe, the flap will go away. Again catch it at some different part, apply suction and continue the capsular axis. This is one thing. I want to add one more thing. Dr. Sadiq talked about the rhexis going to the periphery. So if it goes to the periphery, sometimes it is very difficult to bring the rhexis inside. Various techniques have been described, but I want to add one simple technique which is generally not described or discussed. Why the capsule axis is difficult to bring into the center? Basically, capsule is not a straight surface; it's a curved surface, and there are centrifugal forces of acting on the capsule. These centrifugal forces are because of the zonular stretch. So your capsule axis force is inwards towards the center, while the zonule starts stretching the capsule outwards. That's how our capsule axis keeps going circumferentially. If it goes to the periphery, the centrifugal forces are more. Because you are going to the lower part of the capsule, the centrifugal forces are more. So at this stage, if with any instrument outside, if we can depress the globe in the ciliary body region, wherever the capsule axis is going periphery, in that meridian, you depress the ciliary body in that region, so that will loosen the zonules in that region, and to bring the capsule axis inside becomes comparatively easy, because you are nullifying the centrifugal forces with that indentation. Thank you.
Dr. Boramani,
Yeah.
sir, when you don't have a microcapsular axis forceps and you are doing rhexis with the way you have highlighted, would you like to keep the chamber a little deep with pushing more of viscoelastic, or it makes no difference?
No, making the chamber deep always makes a difference. Chamber has to be maintained deep. I don't use much viscoelastic because I use AC maintainer.
Okay.
But either with AC maintainer or viscoelastics, the deeper the chamber, the centrifugal forces are progressively nullified. So it is always helps the capsule axis. If you work in a shallow entry chamber, the centrifugal forces are high and the chance of going to periphery are very high.
Thank you.
Thank you, sir, for that wonderful technique description. Let me quickly remind you all, we have almost 160 viewers with us on the webpage and YouTube. So to remind the viewers, if you have any question, you can put in the chat box and we can take them up towards the end of the session. So moving on to our last talk. So we have best in the last, Dr. M.S. Ravindra sir, who is teacher of teachers. So sir, we are very excited for your talk, and I will request you to please share your screen and start your presentation, sir.
Good evening. Is that screen visible, Dr. Aarti?
Yes, sir, it's visible.
Is playing?
Yes, sir.
Fine. My congratulations to the team in India and Tanzania, in Nigeria, and I'm grateful to Dr. Sahu for giving me the privilege of sharing my few thoughts on this interesting topic. CCC has become an essential thing in modern cataract surgery for various reasons that were described before, and I congratulate all the previous speakers from whom I learned a lot. Especially Dr. Sadiq, your presentations were marvelous, absolutely great. And similarly, Dr. Mita's and other lectures also. So this is the technique I adopt this point of time. The surgery is being done under topical anesthesia. Just to introduce what I do, that's a 2.8 millimeter keratome. I start about a millimeter away from the limbus, and there's no separate conjunctival incision. This is common for everybody. This is from the temporal side, and I travel about 2.5 to 3 millimeters and enter into the anterior chamber. Ensure that the cuts are parallel to each other. They should not be curving either anteriorly or posteriorly. And now I filled the chamber with viscoelastic. Dr. Sadiq made very, very salient points. One of them is the AC should not shallow, during the procedure. to ensure that AC does not shallow, especially in difficult situations. I have devised a technique. The second thing is ensure that intra-capsular, intra-bag pressure and pressure in the anterior chamber should be same. If one of them is higher, imagine the capsular bag pressure is higher and the AC pressure is lower, and it's going to run the rexis peripherally. To avoid that, what I'm going to do is this AC is filled with viscoelastic. The filling should not be too much. Filling should not be pressurized in the capsule backwards, putting a stretch on the zonules. These zonules should be relaxed or tense or in between the two, but it should not be pressed backwards. So that way the capsule is not being stretched to tear off. So the AC should not be extremely deep. It should be just little more than the normal depth. So what I'm trying to do is, this is cystotome. The cystotome is bent at 45 degrees, not at 90 degrees for various reasons. As I'm moving it forward, I perforate the floor of the tunnel at the limbus. Can you see? That's the point. I've stopped there. I'm just to show it to you, and it'll start now. And you can see it. I perforate there and go inside. Now what's happened is this is closed now. There's nothing can come out. The only communication between the outside and inside the chamber is through a tiny hole, which is not leaking. So any video you see, as the rexis progresses, there's a continuous leak of visco. That means there's a continuous shallowing of the chamber. And in this tunnel floor entry technique of mine, there's nothing. You can also see the capsulotomy is bent at 45 degrees. So now, very comfortably, anybody for that matter can do a rexis of any size. You can stop at any point of time. See, there's no leak of viscoelastic. You can go prefer the choice of your rexis and complete it. So this is the most beautiful way and controlled way of doing a rexis, and that's the end of it. So now there is a very tense bag. What I'm going to do is I would like to release the pressure inside the capsular bag by doing can opening technique. As you can see here, when you do can opening, the normal tendency is to make radial cuts. So I've circumvented that. I make cuts tangentially or in a circumferential manner. As you can see, I can go back a little bit, especially for a beginner, it's useful. See the cuts here? They're tangential, like that. You cut and join to the previous one. You almost get a rexis, like a rexis. So this is a very small, the capsulotomy. I'm joining them to make a complete circle there. The fluid is very tense, but I've closed the tunnel, so there's no leak there, so there's no shallowing of the chamber. I'll join all the cuts, then that's one part of the program, and I'm trying to join them a little bit here and there, as you can see here, but there is still a tension there, still the thing can run to the periphery. Now nucleus is very tightly placed in the capsular bag. I'm trying to rotate it. I'm also watching all the cuts that I made so that it doesn't relax. It's refusing to do. I'm enlarging the tunnel to 5.2 millimeters. That's a standard 5.2 millimeters. Translimbally, there's no congenital flap. Now I'm refilling it. I'm trying to hold the capsular flaps and converting them into rexis. As you can see there, it's a very simple technique. You may have to refill the chamber with viscoelastic periodically, maintain the chamber depth. Maintain the chamber depth. It should not shallow, neither it should be too deep. The third point is do not push the nucleus backwards. When you push the nucleus, when you dip the nucleus backwards for some reason, this rexis is inadequate. I'm again enlarging it so that a large nucleus can be taken out from the capsular bag, as you can see there. And the forces are such that pull it wherever you want. What you have to watch is where it is tearing. If it is tearing in a circumferential manner, you're all right. The next thing is, many times, as you can watch, go back and watch your videos. You see this forceps, you are focusing here, trying to rotate it, but this forceps which is passing across the tunnel is pressing it down. When it presses down, all the equations of the pressure changes and it can run off to the periphery. The forceps actually should float in the plane of the tunnel. Don't lift it up, don't press it down. That way you maintain the equilibrium inside the antechamber. Do not hesitate to refill it again. Come back and refill it again. Take your own time. And now you completed it. I'm very happy. And now I'll just remove the nucleus, rotate it, bisect in the anterior chamber. I'm running it fast for the sake of time. Remove all the cortex. This is the most important thing, especially in mature cataract. Every bit of cortex has to be removed. This is another case, another way, very, very tense bag, as you can see here. And there is a posterior segment problem. Our retinal colleague has already, put the ports there for vitrectomy. See here, I'm trying to go inside, and I'll actually take the shelter of the cannula to pass a needle, and needle goes and perforates and aspirates the liquid cortex. As you can see, everything is going inside. That's a fat needle, and the pressure inside the bag is very less now. Enlarge it by 5.2 millimeters, and then create a rhexis. Pressurize the chamber with viscoelastic. HPMC is all that I need. I don't need any high cost, the high molecular weight, this thing. And as you can see, this is floating. I'm neither pressing the tunnel nor lifting it up. So there's no escape of viscoelastic, or escape is minimal here. When you do a Utrata, the visco will come out, and you have a beautiful, nice tender. I put the lens inside the bag, and my posterior segment colleague will go back and do it. There's another very tense one. I'm just perforating it, trying to aspirate some fluid. Some fluid comes out, not a huge amount. Some of it comes out. You can actually press it. There is a risk of the opening running backwards, running to the periphery. You must stop it and immediately go. This is a large cataract, so I'm going to enlarge the tunnel, hold it. Again, float in the tunnel. That's a word I use. Don't press the eye to pressurize the eye. You can do a very good large rhexis. Do not hesitate to do a large rhexis, especially when you are doing a can opening rhexis. Do a very large rhexis. There's absolutely no problem, never a problem. I mean, the phaco colleagues will say that make a small rhexis, 3 millimeter, 5 millimeter, 8 millimeter, 5.5 millimeter, 5.25. Not necessary. In SICS, do as big, whether you're doing a rhexis or can opening, kindly do a rhexis. This is a very good way of checking whether you have left any cortex. Use a ball dialer to sweep the pupil, dilate it, and go back and see. So put the lens inside the capsular bag, and that's the end of that particular surgery. Ensure that the lens is sitting inside the capsular bag. This is a small people, pseudo exfoliation, pressure is high, glaucomatous patient. I mean, I never use capsular hooks or capsular dilating devices, pupillary dilating devices, I'm sorry. In any case, even in a small pupil like this, you can do a large rhexis. You don't see where it is tearing, but by just reflexes, you can make out where it is tearing, remove the cataract. And small pupil never bothers for a person who is mastered in SICS. I don't have to dilate the pupil, beyond what it dilates. At the end of it, this is a sclerocorneal tunnel. I always put a drop of the glue, fibrin glue, and seal it so that it becomes airtight. It becomes watertight at the end of surgery. That's the first post-op day. This is a case of very challenging case. 15.5 millimeters is the axial length, non-ophthalmos. The tunnel floor entry technique is the only way I can do a rhexis. The chamber is almost non-existing. I've already done a PI. Pressures are little on higher side. I'm doing a very slow, careful rhexis. You can see there's nothing coming out of the eye. Tunnel floor entry technique, where I've entered at a by pinpoint perforation at the limbus. So you can see it's sweeping, and chamber is deeply formed or moderately formed because I need space to run it. I could complete and get a rhexis in a small eye like this. Diameter of the cornea is, you watch that. The lens I have put is a 60 diopter lens, 60 diopter lens. That's what the eye needed. And the patient had marvelous vision. I've done dozens of these non-ophthalmos patients, and that's a PMML lens. You have a 5.5 millimeter dia tunnel, and that goes inside. Rehabilitation is absolutely perfect. The lens is put it in the capsular bag. These are the people who really love the SICS technique. It's almost impossible to do it with a phacoemulsification, and that's the end of it. So when the rhexis runs off, what will you do? This Dr. Mustafa explained. You can actually, I've completed rhexis, but here it's trying to run off. I did not want to take any risk. I just trimmed it with Vanas and I removed the cataract and I'm putting the lens inside the capsular bag. You remember this area which is weaker, and you're not pressurizing the anterior chamber in SICS, and so you can comfortably remove the nucleus and the cortex and put a lens inside the capsular bag. And these people do it very well. Post-operatively, they will not have any decentration or dislocation or whatever it is, and they do pretty well. So do not hesitate to cut off the final flap. There's another one here. So it has run off. I'm trying to push a little more visco into the eye and deepen the chamber, hold it up and pull it to radially towards the center or even away from the direction where you're running it. Many times you can complete the rhexis and do a hydrodissection and remove the cataract and put the lens inside the eye. That's it. There is no need to bandage these eyes. I have 2 more videos. If time permits, I can show, but I can stop here also. Yeah. You want me to, you have time? Dr. Aarti?
Yeah, yes, sir. Maybe we can take up one video, sir.
I'll see where it is.
Yeah. Gulamani sir wanted to had some comments.
Yes.
Yeah. Excellent videos by Dr. M.S. Ravindra. Excellent talks. Your videos are always a treat for the eyes. Now, I want to ask you 2 questions. Yes. You are very fond of doing the tunnel floor entry.
Yes.
Can I ask after this video?
Yeah.
Yeah, please show this video, then I'll ask the question.
Oh, this is similar to the other one. I'll run it very fast. This is hypotonous eye. So it's run off there. I think it's a similar video. It will show more elegantly. Form the chamber, push the flap back to the normal position, hold the flap and pull it to the other direction. You can see the tear of zonules which are attached to the anterior capsule. Then I've retrieved it. It's back to sharing. Yeah.
Dr. Ravindran.
Yes, sir.
Do you take care of raised intra-lenticular pressure while before doing rhexis in white cataract, mortgage cataract? Because it's a controversial issue. Many people do take care, many people do not take care. What is your, personal approach?
Can you repeat the first part of your question, sir? In a white cataract, and what do I take care of?
Intra-lenticular pressure, he says.
Oh, intra-lenticular pressure can be roughly seen at the beginning of surgery by the convexity of the lens. If it's bulging, as I saw a couple of them, these are 2D videos, but when you see under microscope in a retroilluminated pupil, you can see the configuration of the anterior capsule. If it is bulging to the front, it is better to take care of the intra-lenticular pressure. There are 2 ways of it. There is a pressure in the vitreous cavity, there is a more pressure in the lenticular cavity, and there is less pressure in the anterior chamber because you enter it, aqueous comes out, there is the lowest here, the medium in the vitreous cavity, and the maximum in the capsule, in the lens. So what you do is you increase the pressure inside the anterior chamber more than what it is in the lens bag. Keep that pressure throughout the rhexis. That's the secret of my developing the technique of tunnel floor entry technique, where it's trapped inside. Now it's a plaything. Now you can just really play around. So many times, in a very tense, very hypermature cataract, this pressure elevation in the anterior chamber is not adequate. So in those cases, we'll have to aspirate the cortex, reduce the intralenticular pressure, then continue with this. So it all depends upon how you see as you're injecting HPMC. I watch what is happening to the anterior capsule as I push viscoelastic into the anterior chamber. At certain point, I'll stop it, then take the cystotome and do it. So it all depends upon what you see when you start doing the surgery. That's a very good question, Dr. Nepalia. Thank you.
And what is
Can
your
I
take?
just make, oh, sorry,
Last-
sir.
last- What is your take on pre-operative YAG laser capture?
I would,
making few holes and releasing the intra-lenticular pressure and then taking the patient for surgery?
I would not like it, sir. There are easier ways of doing it during surgery. Why complicate the matter? And any lenticular matter that comes in the anterior chamber will start the inflammatory cascade. Lens matter is inflammatory. So why do you want to bring it, and that gap, half an hour, 1 hour, 2 hours, whatever you're going to take, will block the angle region. It becomes a mess, and I wouldn't like it personally.
Yeah, can I ask my 2 questions? Yeah.
Please, Dr. Gulamani.
So see, you have talked about the tunnel floor entry. I'm curious that if at all, for any reason, you have to bring out the capsulorhexis needle during the capsulorhexis and you want to re-enter, is it easier to re-enter through the same opening where you have made, or you have to make a new opening? That is first question.
It's your luck. So you can really see it's you start from the sclera, you go to the limbus, anywhere from posterior to anterior limbus you can enter it. Nowadays I enter at the posterior limbus. The only risk is the needle can touch and injure the peripheral iris, which has never happened. So you just dip and go anteriorly. So the way I take is, the needle is there, it is bent to 45 degrees, 45 degrees. So I go like that, I go flat, and at the limbus I turn it down, enter and go forward. It is 45 degrees because if it's 90 degrees, you have to push it down. Then that opens the tunnel and visco comes off. So if 90 degrees, as you're passing anteriorly, just dip and go inside. Many times you don't even see that I've entered it. I'm already in the anterior chamber.
Yeah. And you talked about HPMC, you always use HPMC, but is there any indication in your cases where you want to use other viscoelastics, or you don't use it at all?
Actually, we have it. For years I have not used it.
Okay.
There's no need.
So even in case of, say, endothelial dystrophy and such cases, you use HPMC only?
For endothelial dystrophy, HPMC is the best one. The next best is chondroitin.
Chondroitin sulfate.
Yeah. Next, the HPMC is the best as far as the protection of endothelium is concerned. There are any number of studies on it. Maybe chondroitin is as good as HPMC, but anything else is less superior to these two as far as endothelial protection is concerned.
Correct. And HPSC, generally we see it gets stuck to the endothelium.
Yes.
But during surgery, sometimes it causes difficulty in the visualizations. And some people, after the nuclear delivery, they wash out the HPMC from the endothelium by flushing. What is your take on it? It should be done, or it is damaging to endothelium?
HPMC is always transparent. I don't think it's ever blocks the vision. But as you rightly said, the hyaluronic acid is very easy to aspirate, while these get stuck everywhere. So when you are removing it, you have to go to the specific places. I go to the angle region. I wash the entire angle region, because not only the endothelium, but the angle also is started with HPMC. You'll have to literally wash out. Otherwise, you'll have post-operative high pressure. I have no post-operative high of pressure at all, because I take care of the angle region. I take care of the capsular bag. I take care of the visco that's trapped under the iris. And of course, reverse flood and remove the visco flood. That's a task. I take 1 or 2 minutes to do this, but that really pays off as far as post-operative comfort of the patient is concerned.
Yeah. Dr. Susan wants to comment something.
At all, because I take care of the angle region, remove the...
I just want... Congratulations. That was just an extraordinarily important talk. And what in particular it strikes me is you really were addressing the fundamental physics behind the problems we have. And that's in different chambers in the eye, we have different pressures. So I appreciate that. And the fact that you're pointing out is that in the incision, that when we flatten the capsule with a viscoelastic, if we leave it there, the capsule is not going to run. The only reason it runs is that we, with our incision, when we're moving our instrument, we're gaping the incision and the viscoelastic is leaving. So this technique, the Remy technique, I love this of just piercing the, and why do I love it so much is it's exactly where I would be doing my capsulorhexis. So I'm not changing to my paracentesis and using forceps. I'm actually very comfortable operating it at my my main incision site, but this is creating a chamber that the pressure is really maintained beautifully. Congratulations. I think that, it's a great technique. And the final thing is the Vision Blue. I can't stress enough. Again, you used that and helped just illustrate how important being able to see properly is. Doing the capsulorhexis, and essentially when the problem with Vision Blue is when you need it, it's not it's too late. You have already passed time of helping yourself. And so that is dealing with difficult cases to use that at all times. It's not expensive, and it will save you probably 1 or 2 anterior vitrectomies for sure.
I would like to point out 2-3 more advantages of tunnel floor entry technique at the limbus. See, when you are trying to take a needle or forceps through a smaller tunnel, side port is a place the beginning people concentrate on the tip of it, and what they are doing to the tunnel, they really don't look at it. If the tunnel is like that, and if needle goes through that, if you are hitting the wall of the tunnel, I mean, the tunnel opens up and it starts leaking. Yeah. So that's one thing. And overlocking, like if you're hitting the wall of it like that, if you're going that side, if you're hitting the wall like that, again, you concord the cornea and the visibility comes down. And the tunnel has to be short. If it is a long tunnel, the very fact that you're pushing the tunnel down and create folds in that area, and when the rhexis comes to that area, you don't see what's happening. So this is far periphery at the limbus, and the visibility of entire circumference of the rhexis and beyond that is absolutely very clear. You're not concocting or distorting the cornea. The second thing is not only the pressure on the tunnel is important, it's a pressure on when you're doing the capsulorhexis, again, it should be floating on the surface without pressing the lens down. The moment you press the lens down, all the forces are acting in a different parameter, different level, and that's the time the rhexis runs off. So never, I think Dr. Sadiq explained that you should only touch the capsule, should not even touch the cortex. One other reason is there's no pressure applied posteriorly, which will alter the forces that are existing there.
Thank you so much, Dr. Ravindra. I want to ask about capsulotomy in difficult situations, such as children with traumatic cataract with absorbed cortex. Capsularhexis seems to be difficult. How do you go about it?
Yeah, it's in the children. It's you may need the higher molecular weight viscoelastics to keep the space formed. I think Dr. Gulamani asked this question. The only indication for higher molecular weight viscoelastics of hyaluronic acid are to maintain the space. If you can't, if you have to, if you have open chamber, if you have to maintain a space, the only way out is put a high viscosity viscoelastic there, and it should not be coming out. It should remain there. And then with micro, the curved forceps, you can go and cut that, create spaces. It's a very slow process. I probably meant a young child with a cataract after an injury. Is that right?
Yes, that's right. Some of the cataracts are absorbed.
You'll have to work slowly, and before you inject viscoelastic, you'll have to stain it under air with blue, trepan blue. That's essential in a child. Then fill it up with visco first, with HPMC first, or a chondroitin first, and then like a soft shell, you put the high molecular weight viscoelastic under that, create space, maintain space, and I do go under the thing and try to manipulate and make multiple incisions with the cystotome. then it may work or may not work. The fibrotic areas has to be cut with nice scissors, which are used by vitrectomy surgeons by and large. And it's a challenge basically, but in many cases you'll be able to achieve it. In children especially, the cortical removal has to be complete. They react very badly for leftover cortex, and then try to put the lens within the capsular bag. If you can, even half the capsular bag, you can open it up, you can put it, and then you can do a posterior capsular access wherever it's possible. You can also use a vitrector machine. Instead of that, if you're comfortable with vitrectomy probe, I'm a trained vitrectomy posterior segment surgeon, and I don't mind using a 23 or 25 gauge cutter in high speed, and actually can shave off everything, leaving behind the peripheral capsule and anterior capsule and the posterior capsule. After putting the lens, you can again go inside and chop the central part of posterior capsule. The entire thing can be done with a vitrectomy probe.
We have a few questions from our audience as well. So this question is for Dr. Gulamani sir, from Dr. Thompson. What instrument do you use to depress the sclera on the ciliary body part?
You can use any instrument. Generally, you have a forceps in your left hand. The same forceps can be used, the closed forceps, to depress the ciliary body. Any instrument will do. Only the ciliary body region should be indented. That's all.
Okay, sir.
Yeah.
Next question we have from Dr. Neeta Sharma. Ravindra sir, maybe you can take up this question. Sir, your take on rhexis under air.
I've done it for decades.
Are you doing it now?
Huh?
Are you doing it now?
No, I've stopped it. I've stopped.
And reason for stopping?
Reason for stopping? The tunnel floor entry technique is a technique I adopted when I developed that rhexis under air. That's a time when trypan blue was not available, and in a mature cataract, we had a lot of mature cataracts. The contrast of seeing the capsular rhexis is much better than under air than under any kind of fluid. Visco was not available at that time. So any mature cataract where I wasn't having good retinal illumination, it's not injecting air, it's a fluid gas exchange. I'm a vitrectomy surgeon. I know the advantages of fluid gas exchange in the posterior segment. So same concept I adopted in the anterior chamber. I removed aqueous and injected air. Air fills the eye completely without anything. Then with the tunnel floor entry technique, we take a cystotome and we can do a real beautiful rhexis in those patients. Why did I change it? Now viscoelastic is available, trypan blue is available. For the last 10 years, maybe about 6 or 7 years, I've stopped using air and I switched over to the technique that you just saw.
Yeah, so we have reached towards the end of the session. Anybody like to comment anything or have any question in mind?
I think what Susan said is importance of staining for every case is very important if you do not have the very advanced microscopes. If you have a stereo coaxial microscope on which if you're working, I don't use trypan blue at all unless I don't have a retinal illumination, the red glow. But if the microscope is not as good as the best that's available in the market, it's advisable, as Dr. Susan said, to stain the capsule so you see it much better.
Sir, is it true that staining the capsule sometimes make it little taut as well? And it increases the consistency. So it will be advisable to use in pediatric or young patients?
Yeah, it does. It does change the consistency of the capsule, but it doesn't make a difference for a good surgeon. Whether it's that way or this way, it doesn't make a difference. It's more for the visibility that you're using rather than trying to change it by any extent, any of the textures.
I just want to say congratulations to all the speakers. This was extraordinary. I was wondering, how could we talk for a whole hour on this topic? But there was no repetition at all. It just was fabulous. And, you know, really thinking three-dimensionally is a critical piece of not fighting the pressure, but seeing how you can work with it. Congratulations. Brilliant.
Professor Nasuru wants to comment something.
Yeah, I just want to highlight a couple of things that I feel for our setting, people need to pay attention. On the capsulotomy needle, angulation was discussed by several speakers, and personally, I go for the 45. I have always find it safer in that you really don't need to push. When it's there at 90, you really kind of don't see what you're doing because it's really covered. At 45, you could really see the tip of your capsulotomy because seeing what you're doing is critical managing that lens. Then staining was emphasized. I truly recommend, we see a lot of white cataracts, and it should be obvious to many of us that units need to stock triform blue. I've been to places you ask for triform blue, they just look at you. So it is important, really, people value triform blue and stock it. It can help them. Then generally start your rexis central. If you start really central, even if it extends, you find you're able to really come round and continue as highlighted. Then the direction of your pull, and then the triangle. You know, the critical thing is you pull closer to the leading edge of your capsule, trying to keep it folded onto itself. And then importantly, keep a deep anterior chamber. Extremely important. You need to realize the more you work with a shallow AC, the more you're damaging the endothelium. And that will further complicate your procedure. So I think these are things that I think I need to highlight. There is never one way of doing things, but I think these are important things we have heard from excellent speakers this afternoon, and I think I just want to echo such things for population, especially around here. Thank you very much for the opportunity.
Thank you so much. We have quite a few comments from our audience. I'll just mention few of them. Dr. Fatima from Nigeria says, brilliant presentation, very educative. Thank you very much. So I am glad that every one of us will benefit from this webinar. Ravindra sir, you were trying to say something?
Okay, what I was trying to say is these are bits and pieces, and you will never build a whole story by looking at it. If anybody, you know, all the centers in Bangalore, I'm sorry, I'm from Bangalore in India. So if anytime you're visiting that, kindly do visit us. So we will certainly discuss the entire surgery in great depth when you are around. So a day's stopover in Bangalore, in my place, or we will really, you'll see the whole thing, bits and pieces. If you join them, I mean, it may not be a good necklace. So if you see the entire thing, it'll be a beautiful, chain made of pearls.
Yeah, so may I now request Syed from NTOT to please run the video. So over to you, Dr. Mustafa, for your closing comments.
Okay, thank you all for coming. The session has been great and beautiful. with brilliant presentations. We thank the ISMSICS founding chapter for a very good session. We are deeply grateful to Dr. Amulia Sangwa and his team, to our presenters, guest speakers from Dr. Abdullah Sadiq and co-presenters from India, and also the panelists that made the presentation and the session very interactive and interesting. Finally, I would like to thank Dr. Ati. She has been an amazing moderator for the session. We would like to see you again soon. Thank you all. Yeah.
Thank you, everyone. Enjoy your morning and afternoon and evening.
Good night from India.
Okay. Thanks everyone.
Compliments to Dr. Aarti Heda for holding such a wonderful session as a wonderful anchor.
She did marvelous. She did marvelous.
Thank you.
Dr. Nasuru,
bye-bye, everyone.
Yeah.
Bye-bye, everyone.
Yeah.
Okay. Thank you.